Okay, we seem to be up and running everywhere now. So once again, thank you everyone for joining us. We've had an unprecedented response to this webinar and we're very grateful to you all for taking the time to come and listen to us today. We hope you find it useful. Just to reiterate once again, we won't be using the put up your hand function and you won't be able to request an opportunity to actually speak during the webinar. If you'd like to ask a question of our panelists, of any of us, please put it in either the question and answer function or the chat function, both of which you can find in the bar at the bottom of your screen. And again, this is mainly aimed at UK patients. I know a few of you have joined us from abroad, but some of the information will be very specific to UK patients. So please bear that in mind when making use of it. So today we are joined by Professor Adam Mead from Oxford. Thank you for joining us, Adam.
Pleasure.
And we're also joined all on one video from guys in London. We've got Professor Claire Harrison, Yvonne Francis and Claire Woodley. Thank you guys for joining us.
No problem.
I've also got my colleague Zach from Leukemia Care answering the questions, and I am Charlotte. I'm the Patient Advocacy Manager here at Leukemia Care. So just to kick off, today we're going to talk about COVID-19 and the coronavirus pandemic and what that may or may not mean for people living with myeloproliferative neoplasms. So we were keen to start by just reiterating that the government guidance that has been public for quite some time now. And then we will discuss with Claire and Adam what this general guidance means for people living with MPNs specifically. So what the government did back on the 16th of March, if my memory serves me correctly, it was a few weeks ago now, they issued guidance that those who they consider most vulnerable to severe coronavirus symptoms, they asked those people to shield and defined who those most vulnerable people are. This included, and I've quoted this directly from the guidance, people with cancers of the blood, bone marrow, blood or bone marrow, such as leukemia, lymphoma and myeloma, who are at any stage of treatment. So the aim of this was to take a cautious approach, so basically to include as many people as possible who may be at risk, in order to reduce sort of the number of severe cases of COVID-19 that we would see in the UK. However, there are some nuances to different blood cancers that can sort of change who has particularly severe immunosuppression, or on the opposite end, people who may not have as severe immunosuppression as this guidance suggests. And Claire and Adam and Yvonne and Claire as well will go over what their opinion is on sort of the particular nuances for MPN patients. We also just wanted to go over what shielding actually means, because we believe there's been a little bit of confusion between shielding and self-isolating. So shielding is this process that Public Health England and the NHS and the government have come up with for specifically for those they consider most vulnerable, whereas self-isolating is the advice that people should undertake should they actually experience symptoms of coronavirus. And shielding is different in that they've advised that people don't leave the home for an initial period of 12 weeks, which is due to expire sometime in the middle of June. And this includes even for exercise. So this is how shielding differs from the general social distancing advice that people have been advised to do generally. The only exception to this is for medical appointments, and I'll come back to that later. Additionally, we've had quite a few questions of people wanting to shield but concerned about other people in their household leaving the house still. And the official guidance on this is there is no need for people who live with you to shield as well, but you must social distance from other people living in the house with you who continue to leave the house. Now we appreciate that's a tricky situation to be in, depending on whether you're caring for someone you live with or whether you just simply don't have the space. And our contact details will be at the end of this. We're happy to assist you with this if you feel like that's not possible. What if I don't have a letter? Now, The NHS have been sending out letters to all those people that they considered vulnerable based on the criteria I said in the first slide, sorry. But there was local responsibility to follow this up, say from hospitals, and local GPs were both asked, depending on exact location, to follow this up. It's important to consider whether so based on what Claire and Adam are going to say in a bit, you could then work out for yourself whether you still feel like you need a letter, and it's good to consult with your own clinician as to this. But there are ways you can register for support without that letter if you still feel you want to shield in the meantime. In England, there is a central system, and you can also go to your local councils. And in Wales, Scotland and Northern Ireland, it's also recommended that you contact your local council. And if after this webinar you're still not sure whether you should be shielding or not, we urge you to contact either your haematologist or your GP, and get in contact with us if you need further support. Apart from shielding, I wanted to just briefly mention potential treatment changes that you may or may not have experienced since the coronavirus pandemic started. We were advised that doctors were being encouraged to make individual risk-benefit analyses of every intervention. So this means every blood test you may need, every appointment you may need, to decide whether that is still important. However, it's important to note that if you need treatment urgently, this is still a priority. There has not been a blanket recommendation that cancer treatment stops altogether. There's very much been a system of making sure those most in need are prioritised. And there's been general guidance from both NHS England and from the National Institute of Health and Care Excellence on this. And how this relates to MPN patients, I will let Claire and Adam explain any changes you may have been experiencing, or please feel free to ask questions on this as well. If you are asked to attend an appointment and that your clinical team think is important, please go to it, because they will have made this risk-benefit analysis as to whether you are more at risk of coronavirus if you go, or whether you need that appointment, and the risk is worth taking. And ask if you aren't sure. You are still able to have that conversation. You should still be able, sorry, to have that conversation with your clinical team if you are concerned about whether something is necessary or not. And I think this is probably a good point for me to pass on to Claire and Adam, and Yvonne and Claire to begin their presentation. So just let me know when you want to change slides.
Okay, thanks very much, Charlotte, and thanks for the opportunity to talk today and to answer questions, because I know there are a lot, and this is quite obviously has been and remains quite a time of a lot of change and concern. So we put together a few slides just to kind of give you some perspective, and Adam's got some exciting slides at the end to talk to you about clinical trials. One of the important things for us in hospital has been to understand the data and understand what's happening locally. So thought it might be interesting for you to just take a look at this data, which is actually from this morning at Guy's and St Thomas's, and shows you on the left is the number of positive tests we've had and admissions, and you can see that there's been a peak and the number of those is coming down. So the positive test admissions is the orange line, and the grey line is patients the dark grey line is patients who've been discharged. We've definitely had a lot of patients through the hospital, and a lot of our normal activity has stopped or switched, and we'll talk about that shortly. I think it's also important to notice on the right-hand side that we have been discharging a lot of patients. A lot of patients have been doing well, and we are avidly consuming data, sharing data as groups of clinicians. The MPN doctors have got together to pull together advice. We're sharing with colleagues internationally and discussing what to do. And we're understanding our own data. So our own data, and this is just Guy's and St Thomas's, for example, our in-hospital mortality rate is still shocking, but it's not as bad, for example, as it was in China or as it currently is in some other parts of the world. Let's move to the next slide and think about what things we've been doing in hospitals that might affect you as patients. So you will have noticed that in general, we've rapidly moved to sort of telemedicine. We've usually been using the telephone, although we do have some sort of video conferencing facilities. These are quite tricky to handle for us, as well as perhaps for you guys too, although we're getting better at that kind of technology. That's been really important for us because it's freed up capacity in the team, because many of us have had some of our teams working elsewhere, working on the wards or working in critical care, or our team members have been sick or have had family members who are unwell. We've also made a huge effort to send medication out to patients, so it's become really critical to work closely with pharmacy, but also that we have accurate details for you. So we've had some problems with wrong telephone numbers, people who've moved. So in terms of our inpatient facilities, not so relevant for MPN, but day units are very relevant, obviously, if you're coming for transfusion or perhaps a venous section. So what you would be seeing, as Charlotte said, is we'd be keeping attendances to a minimum, only bringing patients up when we really think we need to. We're keeping a clean unit, so patients are coming in, being asked about symptoms, they're having a temperature taken, they're given a mask, staff are wearing scrubs or uniforms, masks, etc. And we're swabbing patients wherever we have a suspicion. In terms of clinical trials, as you know, we're very active in clinical trials across the UK, and many of you may well be in a clinical trial or interested in a trial. We've generally stopped recruitment because early in a trial, we have to see patients a lot to do safety checks. But for those patients who are established in a clinical trial, we've reduced monitoring. And that is not something that individual hospitals have taken a decision on. That's been a decision taken nationally by the MHRA, but also internationally by sponsors of trials. Just looking forward, I would say it's not clear when we will resume a normal service or what a normal service will look like. Some of us are starting to look now at, well, can we increase a tiny bit? Like you saw on the graph that London is definitely past at least its peak at the moment. It might be a little bit safer for people to come into hospital. But I would urge you still to remain at home where possible and follow government's advice, of course. And there have been many positives to this new way of working, which we're trying to keep in terms of our working. Maybe we can move to the next slide and Yvonne can speak.
So I just wanted to give you a little bit of an insight into the experiences that mainly Claire, Woody and I have been hearing from the patients, ringing in or emailing. And interestingly, whilst our face-to-face patient interactions has reduced right down, the calls and the emails, I think the last report was increasing by about 300% because we get a very high number of calls from patients wanting clarification or are concerned and not sure. There's a lot of confusion out there about whether people should be shielding or shouldn't be, and still people are only just getting messages coming through from the government by letter, by text, or even by phone calls. We've had people today ringing us saying that they should be shielded and they didn't realise they should be shielded and what should they do. So you may not have received a letter or a call, and you may still receive one as yet, and that's because obviously it's taken quite a long time for the government to collate all their records. I think we've mentioned Charlotte's mentioned about what strict shielding involves, and I think we've had people bringing in again a range of, for example, a 30-year-old lady with ET on aspirin who doesn't really feel that she's at risk, so why should she be shielding and why should be going to work, to other patients who are on hydroxycarbamide, ruxolitinib, who want to be shielding but they need proof of letters. So again, this is a very subjective situation and everybody's interpreting things slightly different. From our point of view, we are guided by the government, but Adam and Claire are probably going to hopefully expand a little bit later in the future in the webinar on the slight changes and disparities. Really, very importantly, hospitals are still open, as are GP surgeries and as is A&E and acute oncology services. And if you are unwell, you should not delay getting a medical response. It's really important to reiterate that. GPs are doing remote telephone calls the same as we are, and A&Es are still taking patients. And a lot of hospitals are doing the same as we are, making sure that we've got social distancing in order for the patients. We're all wearing PPE. Patients are being swabbed potentially and given masks as they're coming in. So we are trying to keep you and us as safe as possible while still giving you the care that you need. It's really difficult at the moment while you're being told to shield, you're being left at home. We're going to move on to the next slide, and Claire's just going to talk about some potential strategies to help you manage the situation.
I felt it was important to recognise the psychological and emotional impact that this situation is currently having on us. There are many anxieties that you may be experiencing to do with your underlying condition, how catching COVID may affect you, how it may be affecting your family, your friends, what it's perhaps doing to your job, your finances. And it's important to say that these are normal feelings that you're all having. There are feelings that many of us are going through, and it's important to share these feelings, to express what it is that is happening for you, how you are feeling at home. You can happily contact your clinical team. It may take us a little while to get back to you because some of us will be moving around our hospitals in different environments, but there will be somebody that will be able to get back to you. It's also important to acknowledge that there are other places that we can go and receive support. There are certain apps that can help calm our minds, such as Headspace. There are other services that are available both through Leukemia Care and through MPN Voice. On the screen at the moment are some of the suggestions that our psychology team here at NICE have come up with to help you manage. So things such as trust your MPN condition, trust how you are feeling, you will know what symptoms you experience, and if you have problems, then contact your clinical team. Acknowledge that actually we are having strange feelings. Recognise these, recognise that actually it is unusual for us, but to pause and to acknowledge these feelings. In this time where we're telling you to isolate, the internet becomes our best friend, but it is also our foe at times. There is a lot of information that is out there that may not be accurate. So please bear in mind this when you're looking at all the different sites. Use the recognised government websites, the NHS websites. It's important to take time to feel calm, to kind of stay in the present moment and to acknowledge what is happening. I know for us as a clinical team here, we appreciate our patients calling us. We take as much from your calls to us as what we hope that we can give you too.
Okay, thanks very much, Claire. I think that's really helpful. It's certainly something that I've also been kind of thinking about. Maybe we can move to the next slide. So I mentioned that we, as a group of clinical colleagues, so nurses, doctors, some scientists as well, have been gathered together and having discussions about MPN kind of issues with COVID. And these are, in brief, some kind of questions and answers that we've been looking at with colleagues internationally. And these are available to clinical teams across the UK, across Europe, and through the American Society of Hematology. They thought it might be useful for just kind of sharing them as a framework for discussion. Generally, should we reduce your drug to decrease the risk of developing COVID disease? No. There's no evidence definitively that any of the drugs we use increase the risk. So unless your team has told you to reduce the dose or adjust the dose, please don't do it. Specifically, JAK inhibitors are of interest, and indeed a couple of them are being tried to treat COVID Part of the issue is a kind of storm of cytokines, but we definitely wouldn't adjust them other than for clinical reasons, and we would definitely say do not stop these drugs, as we would normally say, don't stop these drugs quickly, because you may cause a kind of storm of cytokines, which is similar to some of the problems that patients are having with COVID. What about new patients? Very anxious time for them. What would we do? We would be carefully weighing up the risk. If we think that patient's a low risk patient, we might defer them coming up. If we think they're at high risk, they've recently had a blood clot, we would definitely be wanting to think about starting treatment. But we'd be looking around at what does the pandemic look like in our area, how can we safely manage them. If you do develop COVID-19 infection, it's quite clear to us, as we've been calling patients that quite a few patients have, should we be adjusting or stopping the MPN treatment? No, is the general answer, unless there's an issue with drug interaction. And it's important, if you have the details of your disease, a recent clinic letter or one of the cards that MPN Voice provides, to take that with you. Of particular interest for MPN patients is this issue of COVID-19 patients developing blood clots. And we've received a lot of emails about this, as this becomes, we're more aware of this and it becomes more public knowledge. Is this a particular problem for MPN? We don't think so, but we need to be aware of medication that patients are taking, and often we would be switching from a drug like warfarin or rivaroxaban to heparin if a patient is, for example. One last point before I hand over to Adam on this is there's been a lot of discussion about risk with Brufen, which is a non-steroidal anti-inflammatory drug, and risk with COVID-19. I think that that is pretty much been overturned now, but I wouldn't want any MPN patients stopping their aspirin, which is related to Brufen, on the basis of that. So please don't stop that drug. So Adam, I'm going to hand over to you now. And Charlotte, could we change a slide?
Great. Thank you very much. I thought it'd be useful to take a forward look at what's happening with coronavirus, because I think for all of us it feels like an absolute age that this virus has already been around. And whilst it's clear that the virus outbreak in the UK, the first outbreak at least, has peaked probably in early April, it also appears, looking at other European countries, like the downslope of the epidemic is likely to be quite slow. So this is likely to be a virus that we're dealing with for quite some time to come. And I wanted to just think a little bit about the strategies that are being explored to deal with that. I mean, first and foremost, at the moment, those are public health strategies, of course. So all the things that you've been hearing about, the social distancing, potentially there may be questions about the value of wearing masks when out in public. We could discuss that. Contact tracing and testing. Just briefly on testing, obviously it's been quite controversial, the amount of testing capabilities in the UK, and we've set some targets for that. What I would say is that I've seen enormous efforts going on certainly in our region, and I know nationally, to set up increasing testing capability. We're helping with that in my laboratory, and I think that's going to be one of the crucial ways to get this current epidemic under control. But in the longer term, the way of dealing with this is herd immunity. And herd immunity, of course, is also controversial when that was mentioned by the government, but by far the best way to get herd immunity is through vaccination. And as you've heard in the news, there are two groups in the UK, one in Oxford and one at Imperial College, who have already got a vaccine that's being developed against this virus. I mean, it's worth just reflecting on that this virus was first discovered and reported towards the end of December last year. So it's been around for 3 or 4 months. And the speed at which we've learned about this virus through scientific research has been truly remarkable. So the Oxford group have developed a vaccine. They have already developed a similar vaccine to a very closely related coronavirus that caused a closely related disease called MERS. So they know there's quite a good chance that this type of vaccine approach will work. And they already have commenced a clinical trial. So patients have already started receiving this vaccine. And they're planning a trial of over 1,000 patients. So towards the end of the summer, early autumn, we will have some clear indications as to whether this vaccine is likely to work. And we're all keeping our fingers crossed. But remember, we're not just relying on Oxford or Imperial. There are, in fact, 80 research groups around the world who are developing vaccines, many of which are already in clinical trials. And I think that offers real hope that towards the end of this year, we will have vaccines that might be ready to start being rolled out. Okay, next slide, please. So the other aspect of treating this virus is not the herd immunity, but it's actually treating people that develop the infection. And there again, there's been truly remarkable progress. So this is a very complicated slide. I'm not going to talk through the details of it. But what I want to get across in this slide is this is a summary of all the different trials that are going on around the world with different potential drug treatments to treat the coronavirus infection. So it's been a remarkable effort. I would also draw your attention to the fact that you won't see disinfectant anywhere on this particular slide, as was promoted by famously by Donald Trump. But there's much more promising therapies coming through. And in the UK, again, it's been really remarkable to see how the NHS and the related research networks have pulled together. So there's a trial called Recovery that is being led from Oxford that started towards the end of March and has already recruited 8,000 participants. So it's a hugely powered study. We will really learn a lot about some of these new treatments coming through. And the reports of that study, at least the first randomizations on that study, are expected in late May or June. Okay, next slide. But already there are some smaller trials that are reporting significant hope. So this was very hot off the press. The details of this study are not even released yet, but the researchers were sufficiently encouraged by their preliminary look at the data that they put out a press release relating to this drug, tocilizumab, which is an anti-inflammatory treatment. This was a small randomized study of about 60 patients in each arm, showing that when people are admitted with moderate or severe coronavirus infection, it can reduce the rates of death or need for ventilation in the intensive care unit. So I just wanted to show this, that there's really promising data coming through at speed, not only about how we get ways to deal with the epidemic using vaccines, but also ways of treating patients who have the active infection. Okay, next slide, please. So I think this is the final slide, and that's just really for me to thank Leukemia Care for organizing this, and to thank you all for the message of support you've been sending through. And I would also ask you to appreciate that if you sent in queries to your local team or to some of the support groups, just bear with us, because you can imagine it's an exceedingly busy time at the moment. It may take a little longer to respond than it is typical, but we will get back to you as soon as we are possibly able to. So thank you very much.
Thank you, Adam. It's nice to hear some positive news as well as always talking about some of the negative. So that's really, really great. I think we'll just move straight into the questions. I'm seeing many coming through. I'll stop sharing my screen now so all participants can see us. Zach, what would you like to start with?
Yes, so just to comment a couple of things before we start with things that have been coming through from the chat. We're monitoring all questions that have come through either on Facebook, the Q&A, or the chat, and in advance. So if anyone's worried about where they've commented, that we have got them. We're going to try and answer the common ones that are coming through in the common themes, because we have had literally hundreds of questions. So if yours isn't answered during this, please do feel free to reach out to either Leukemia Care or MPN Voice. Okay, so let's start with some of the ones that are coming through specifically in relation to COVID-19 more clinically. Do we know whether there are any specific symptoms of coronavirus that patients who have an MPN are more likely to get or more likely to suffer with more significantly? Adam, Claire, I don't know if either of you want to comment on that.
I think we're still in the phase, well, the short answer is no. It doesn't appear that there are any specific presentations we would expect with patients with myeloproliferative neoplasms. The longer, slightly long answer is that we really need to learn more about exactly that type of question. So there are huge efforts that are ongoing to collect data from patients, including MPN patients who have or have not yet had the coronavirus, so that we can understand more about that. But there are no clear signals so far that there are specific ways that patients with MPN present with this disease.
Excellent. And
completely agree. Sorry, go on, Zach.
No, you go.
I'd say I completely agree, but what we would note is that even as we see, staff develop symptoms, that the symptoms are very variable. I want to reassure everybody that there's no reason why a patient with an MPN per se, unless you've got another related condition or you've had a severe complication of your MPN, there's no reason why you should have a more severe episode of coronavirus. And some people just get one temperature, one episode of a sore throat, headache, feel very tired. And we would swab them as staff in hospital because we don't want to expose patients to risk. So we see that, for many patients, I do believe this is a mild.
Absolutely. Even 1 in 5 patients presents mainly with gastrointestinal symptoms, in fact, which is slightly under-recognized. There's a big study out just today, in fact, showing that about 1 in 5 present with vomiting, tummy upset. So it's not just about cough and fever.
And if any MPN patients do get symptoms of coronavirus, obviously unconfirmed at that point, what should they be doing? Should they be letting their haematology team know? Should they be contacting general COVID care at their local hospital?
I think the important thing is to follow their NHS advice, and just stick to government advice, but be aware of the fact, how you would normally feel with your MPN, and be aware that not every fever, for example, is a COVID fever. Not every episode of upset stomach relates to. So if you're not sure, do contact us, but don't contact us if you're really sick. If you're really sick, you should be following the routine emergency route, contacting your GP, etc. So as what we were saying, it's very important to remember hospitals are still open, still important.
In the Oxford region, we've, our triage service has been kind of expanded. So we've asked for all our patients to be the first port of call, unless it's an emergency situation, as Claire says. So contact us first and we will give you the advice what to do next.
Okay, so some questions in relation to shielding and MPNs again, just specifically around, so the government guidance is that anybody with a type of blood cancer should be shielding. Can we just repeat again, Adam and then Claire, what your guidance is for MPN patients? What should they be doing? If they've received a letter, should they be following that? And if they've not received a letter, should they be requesting one?
Okay, should I take this first, Claire, and then you can?
Yes, go ahead.
So I think we've all found this a little bit difficult because this is such a new and rapidly moving situation. And I think the government and patient advocacy groups quite rightly decided to go for a minimum risk approach, which is to say everyone with a blood cancer should shield. And strictly speaking, of course, myeloproliferative neoplasms can be classified as blood cancers. So that does encompass all patients with MPN. I think it's important to recognize that this is not based on specific data that MPN patients are at particular risk. We do not know that yet. So our view on this was that is a sensible approach, but on a per patient basis, the approach can be more nuanced. So there are some patients who probably are at increased risk, for patients with more advanced disease, patients on particular treatments that might be immune suppressive. But there are definitely patients who are at less increased risk, younger patients who may not even be on any cytoreductive treatment as yet. So that my personal approach for this has been to try and personalize the management for specific patients. Some patients are very keen to self-isolate and or shield. Some patients are very keen, depending on their personal circumstances, to carry on working, for instance. And in some cases, in my view, that remains appropriate. So if you've got any doubt, my recommendation will be to contact your local team and we can talk through the pros and cons of them.
So I think I agree with you, Adam. This is difficult, and I'm just going to ask Yvonne and or Claire to comment on that, because often that's probably one of the commonest questions that's coming in. It's very difficult to be specific, but I think you guys should comment on that.
I think yes, it is very difficult. I think the opportunity for full shielding is there if you wish to have it, and that is for your protection. However, we do see, as I said before, that we have some, for example, young low-risk ET patients ringing and saying, well, why can't I go to work? I can't shield. I've got children in the house. What should I do? Can I go for a walk in the garden? Can I go for a jog at midnight when there's no one else around, for example? We are constantly weighing up the risks and helping to guide the patient for them to try and make a sensible decision on how they're going to take this forward. There are obviously some cases where we will be very strict and say categorically you must stay inside and shield, and for your own good. But there are also other times when we can discuss things through again personally and maybe come up with a slightly less severe option, but making sure that people still remain protected as sensibly as possible.
The other comment I would make is that we did release some kind of our guidance and our own views as experts in the MPN field to give people a little bit more specific advice that is available on the MPN Voice website.
Excellent, thank you. We've had lots of comments coming in saying that's quite helpful, the extra explanation you've both just given there. Some follow-up questions. If a patient with MPN is shielding and considered to be particularly high risk for MPN, should people they live with also be shielding if they're unable to socially distance at more than 2 meters from them, or sleep in a separate room, or clean spaces as the government guidance is asking them to do? Again, Adam, do you want to take this one first, and then Claire and the team?
I think it's kind of a similar answer, because we appreciate that it has to be adapted to people's personal circumstances. In some cases, they're at home and living in a situation where it's just simply not possible to follow those strictest shielding measures. And I think it has to be adapted to people's personal situations. But in the patients who are at the highest risk, that might be patients with more advanced forms of myeloproliferative neoplasm, such as myelofibrosis that may be on treatments that are more immune suppressive. I think it probably is desirable if people are in a situation where it's possible for everyone in a household to shield. Yeah, but it's not always possible to do that, and then I think you have to adapt to the situation. But I've certainly got some patients who fall into that category who are managing to shield at home. Claire, I don't know if you want to.
So I think this is a tough thing, isn't it? So I'm not sure exactly what to add, except I would say that we have staff who are in that position. So we have staff who, and in their household is somebody who needs to shield, who is extremely vulnerable. And, you know, not everyone lives in a household where it's really possible to have that kind of social distancing. So some of those staff have made the decision to shield at home with their children or their parents, etc. But some of them are actually staying in a hotel or staying with a friend so that they can come to work. So that's just an illustration of, you know, the kind of flexibility. But there's also this nuanced interpretation of shielding, which is a general measure put in for the safety of the general population. It can never be completely individualised. So I think, you know, if you're not sure and it's causing stress, discuss it with your healthcare team, discuss it with your GP, talk it through. Then you're also sharing the responsibility as well. So I think it must be very stressful.
So one question we're getting quite a lot is, we're talking about drugs that may be considered immunosuppressive. Could we give some examples of drugs that are immunosuppressive and then some drugs that aren't, in terms of, particularly we're hearing hydroxycarbamide, would that cause you to need to shield? Again, Adam, you're smiling, so I'll let you take this one first again.
I'll stop smiling. So I think, you know, aspirin is of course not immune suppressive, although people may have seen that there were concerns about anti-inflammatory drugs in association with coronavirus. That does not appear to be a concern specifically for aspirin, so that's an important point. Aspirin is very important treatment for MPN patients, and that should continue. With regards to cytoreductive treatments, I think there are variable degrees of immune suppression. There is an argument that most of the cytoreductive treatments are associated with a degree of immune suppression, but it is more severe for some than for others. So hydroxycarbamide, I would say, is not a particularly strongly immune suppressive treatment. Ruxolitinib is a stronger immune suppressive treatment, and in my view probably does warrant, for people receiving ruxolitinib Jakavi treatment, it does warrant more stringent social distancing approaches and or shielding. Interferon, I think, is difficult. Interferon can be an immune suppressive treatment, but at the same time can be an immune stimulating treatment, and in fact is a hormone made by the body in response to viral infections, and is in clinical trials as a treatment for coronavirus, as is ruxolitinib. So there are two sides to each of these particular drugs. Hopefully that's a helpful answer.
Thank you. Hopefully that answers the questions, because we've had quite a few come through on that. So a question in terms of, for those who are shielding either by choice or because they've received a letter and feel they should do so, is it okay to leave the house to go for blood tests at the hospital if they've been requested to do so? And we've also had questions in relation to venesection and whether they should be continuing doing that if it's something they were already doing. We'll pick on Claire and the team first this time.
I think that, you know, that's exactly the type of thing that, you know, the clinical team will be thinking about. How safe is it for this patient to go for this test? Do I really need it? And we've cut down a lot. But I think if you're worried about the safety of that, then you need to discuss it with your clinical team. Ideally, for example, you shouldn't be coming on public transport, and or if you need to, we would discuss with you the best way to do that. I think in Oxford, you're a bit lucky, Adam, aren't you? Because patients can obviously drive up and stick their arm out of the car, get their bloods done. But I don't think that they can get a venesection done like that. So in our day unit or ambulatory unit, we've made big efforts to make sure that the environment is safe for patients. You know, talk to your team.
I think it's also important to say that actually a lot of GP and community services have worked really hard to work with us to develop ways for patients to have their bloods taken with minimal exposure for patients. They've moved really rapidly and are supporting our services extensively.
Thank you for that. So another question we're getting in terms of, again, for those who are shielding, if they're struggling to get supermarket deliveries, if they're struggling to get access to other forms of support, what should they be doing? I don't know whether Charlotte, from a leukemia care perspective, you want to comment on this as well.
Yeah. So if you're having trouble, I think everybody's sort of focused on going to supermarkets directly, but actually there are sort of more local schemes in place that can get you what you need perhaps a little quicker than the supermarkets. So we've had a lot of success with contacting local councils, and a lot of them have their own volunteering schemes in place, and we just had an update on the NHS volunteering scheme earlier this morning that let us know that patients can now self-refer to that scheme as well. So if you are shielding and in the vulnerable category, you can apply to have one of the NHS volunteers do your shopping for you. So there are other options, and I'd encourage you to get in touch with either us at Leukemia Care or at MPN Voice, and we can help you sort of find out more, particularly if you're not internet savvy, because quite a lot of this information is sort of buried in the internet. We're more than happy to help talk you through what's available in your local area.
Just to second that, I've had a few patients today who've said that their local councils are delivering food boxes, the Red Cross are delivering food boxes, so there are things that are out there for you to access.
Absolutely, it's just if you're having trouble finding them, we're more than happy to help to find those.
So we're getting quite a few questions in terms of exercise. Again, those who either are shielding or who are socially distancing quite a lot. Is going outside for a daily walk a sensible idea? Is that something, and should they be trying to do it at, I don't know who mentioned it, at a time when there's less likely to be people around?
I think someone said midnight, but I wouldn't do that personally. Here's that question.
I jested about midnight when no one else was around, but we've had a lot of calls about that. Now, obviously, if you are strictly shielding, then no, you would not be going out. If you are choosing that actually self-isolation is more for you, then actually the guidelines for self-isolation is that you can go out, but you need to make sure you're staying sort of 2 meters away from people. I mean, they've closed all the children's parks and that, so they're not touching swings and slides, and so you also want to be thinking about what you're touching and contacting, and ideally try not. The parks are getting busier, the paths are getting busier. People are coming out, or try and pick a time when you are less likely to be put in a situation where you are around people. We do appreciate that not everybody's lucky enough to have a garden, and we have to weigh up the pros and cons of how people's anxieties and the fact that they're feeling very stressed being inside, and all this is the kind of stuff that we're weighing up where we're trying to help people to make decisions.
Thank you. So we've got another question in terms of support available. So those who either are shielding or want to stay at home more, perhaps to work from home, if their employer won't let them do that. Charlotte, can you comment on what Leukemia Care are doing in relation to this?
Yes, so if you haven't received a letter, but you think you should be shielding either based on something you've heard from your own doctors or based on the general government guidance, if you think that's applied to you, please get in touch. Basically, we can help you sort of communicate with your employer to try and explain a bit more of the situation. So for example, you can be furloughed even if nobody else has been furloughed in your company, if you are employed, of course. If you are shielding, that is part of the furlough, the coronavirus retention scheme guidelines, is that you can be furloughed, and just you can be furloughed if necessary. So there are options out there for people who are shielding, and if you're having trouble explaining it, to your employer, or they're not quite sure what applies to them, either put them in touch with us and we'd be more than happy to explain, or you get in touch with us and we'll help you communicate that with your employer as best we can.
Okay, thank you. I think we've got time for just one more question, and something we've seen come through a couple of times is a question in relation to reports that coronavirus may increase the risk of clotting. Is that something that MPN patients who are already at risk of that should be particularly worried about? Claire, you look like you're itching to say something.
Well, I did say something about that actually. So that's something that we've been discussing internationally. So it's a great example of kind of collaboration and learning. And there is advice on that on the European Hematology and American Society of Hematology websites. And there's a link actually to MPN advice on the British Society website too. I think if you have already had a thrombosis, and we know many patients with MPN have, then your risk of another thrombosis is higher, but it doesn't mean it's higher if you've got the coronavirus. But you should, if you are in hospital, you will be given preventative drugs for blood thinning. If you find that you're at home a lot, it's one of the reasons that it's important to exercise and keep mobile. We do not know if MPN patients are more at risk of the blood clotting complications of coronavirus. The cause of them, we think, is related to inflammation linked to the virus. So it's not the same as the cause of a blood clot, for example, due to MPN. But this is something that we will be aware of. Of course, many of you experience that a lot of the medical profession do not know what an MPN is. So important to kind of, say, I have a sticky blood condition if you do need to go into hospital. But we do think about blood clots for every single patient who's admitted to hospital. Every single patient in the UK who's admitted to hospital goes through an assessment of their blood clot risk, and they usually will receive a preventative medication. This is one of the things we're studying.
Thanks, Claire. So just to comment on a couple of things that we've had coming through. Some people are saying they've had a couple of problems with the audio. This is being recorded and will be available for people to watch as long as this guidance remains relevant. So you'll be able to find that either on the MPN Voice website, on the Leukemia Care Facebook page, and Leukemia Care website as well, if you want to watch and listen more closely to particular bits of it. Another question about how guidance may change in the future. This is obviously guidance for the moment based on what's currently known. We are looking as to organising potentially more of these in a couple of weeks' time, and obviously we'll share details of those from Leukemia Care and MPN Voice as and when that is available. And then we've also had a final question, which I think links quite nicely just to close it up, because we're now at 4 o'clock, in terms of what people should do if they want to reach out for further questions. And I know, Charlotte, you've got a slide for both MPN Voice and Leukemia Care on this.
I do, yeah. So this is for MPN Voice. You can see the website there is mpnvoice.org.uk, and I have to say MPN Voice have been really, really great at putting together the specific types of MPNs and treatments and how that might affect your risk. So I'd say they're the go-to people for that information, but obviously they provide lots of information and support services that you can see on the screen there. And also you can contact them directly by emailing info@mpnvoice.org.uk. And in terms of what's available from us at Leukemia Care, we've also got lots of information going out, newsletters, magazines, podcasts, both on coronavirus and also a couple of topics to try and distract you from coronavirus related topics, if that's what you're looking for too. And I've just popped at the bottom there our helpline and our advocacy at leukemiacare.org.uk email address. Those are the first places to go if you've got any questions related to any of the topics we've discussed today. Thanks to MPN Voice also for helping us recruit for this webinar and organise it, and inviting Adam and Claire. And there are also a couple of other places you could go for support, such as Blood Cancer UK, if you want to. Zach, did you want to add something?
Yeah, just to say again to the speakers and everyone who's attended, thank you very much. I don't know if you can see the chat function is literally exploding with thank you messages coming in right now. So I think it's really been appreciated. I mean, it's literally still coming. If anyone can't see it, do go and look afterwards. But I hope everyone found this useful, and we will look to try and do something as and when the guidance changes. So thank you everyone for joining. Thank you for your time, and particularly thank you for the panelists.
Thank
Thank you.
Thank you.
Bye-bye.
you. Bye.
See you.